now we get into our next section, which are our third wave or cognitive behavioral therapies. Basically, we first had sort of our talk therapies, then we had the behavior therapies, because we've kind of framed it before where the psychodynamic and humanistic perspectives were kind of combative at the beginning. We then sort of shifted in the opposite direction where we went into our external focus with behavioral therapies. And then we started shifting back towards cognitive therapy. And our sort of middle ground is cognitive behavioral therapy, a combination of our behavioral components, but also while considering our cognitive aspects as well. So because this is sort of our third step or third broad category, that's why they called it the third wave. That's really the only reason. But one of the biggest focuses, and this is closer to where we are nowadays, this is a lot more modern in terms of perspectives. This is where we started to see a focus on mindfulness, basically on being aware of things going on in your environment, within yourself, and just accepting those situations. So this is a big combination going back to some of our humanistic roots, but also introducing some Eastern perspectives. And so there's a bunch of different mindfulness-based approaches, but like we said, focusing on acceptance. So acknowledging that this is happening or I feel this way and accepting it without necessarily having a negative connotation to it. So instead of having a fear response or feeling ashamed or feeling mad or sad, we just acknowledge that there is a situation. And by having that calmer reaction to it, we can reduce maybe some of our maladaptive responses and have a more balanced response. So our acceptance and commitment theory is where we're focusing on mindfulness as a vehicle for change, basically just focusing on that awareness without judgment so that we're no longer having maybe a gut reaction to things. And then we can be aware of our thoughts and feelings. And as we become more aware of them and accepting of them, maybe we're able to think about them objectively and start changing them so we don't have just our gut response and nothing else. One of our specific types of behaviors here is the dialectic behavior therapy, or DBT. And this is something that was specifically designed for use for individuals with borderline personality disorder. And the reason why this specific type of therapy was developed was because individuals with BPD are actually a lot more likely to engage in self-harming behavior. And it tends to coincide with a lot of very negative thoughts and negative framings about themselves and others. And so having this specific DBT approach is kind of a combination of mindfulness, some of our cognitive adjustments where we think about our thought processes and how we can change some maladaptive thought systems. We're looking at some of the humanistic perspectives of what are your individual goals, how are you going to change and move yourself forward, some behavioral stuff, so what behaviors are you engaging in and how can we reduce those, and even some of the psychodynamic therapies getting into where is this coming from. So it's kind of a mixed bag of a therapy, but it actually has been shown to be fairly effective for individuals with borderline personality disorder. And this was just showing our a couple of different techniques. So this was the number of days of alcohol or drug use reported during the 2 months previous to mindfulness-based relapse prevention or a 12-step treatment, basically showing that our mindfulness effects, because mindfulness on the surface seems like a very simple concept of just sort of thinking and accepting and acknowledging certain feelings and emotions and occurrences and events, and sort of removing the judgment from them. So a lot of people were very untrusting that it would actually have a massive impact, but it seems to be pretty much just as effective as a 12-step program, at least in this particular study. There have been a bunch of follow-ups to see, is it something that's very effective? And it does seem to have a lot of comparable effects to some standing treatment procedures. This is, of course, a newer approach, so it doesn't have as much evidence behind it yet, but they're still in the process of gathering that. So for this section, we are looking at culture and gender issues, stuff that I had mentioned earlier on, where both can play a pretty major role. One of the things that we have to deal with, so when we're looking at psychotherapy, There are definitely cultural factors that are involved. So there's cultural factors involved in seeking out treatment. There's also cultural factors involved in the method of treatment and what is prioritized in treatment. We've even mentioned that different parts of the world use different diagnostic manuals and frame things in very different ways. So depending on where in the world you are, there's a whole bunch of moving parts that can affect if you seek treatment, what kind of treatment is available to you, and the effectiveness of that treatment. So there's lots and lots of different effects there, or a lot of different things that are moved on. So most of, I think we've focused on this quite a few times already. We've been focusing on a lot of research that comes out of North America and Western Europe, not always anywhere else in the world. That's something that's slowly been improving, but like I always mention, our textbooks are fairly far behind, and they're very non-inclusive in where their research is drawn. So a lot of the concepts that we've been looking at, even the disorders and the studies that we've looked at, most of them are very North American centric. So we've been focusing on a lot of individualistic cultures and therefore individualistic framings of these disorders. And because of different cultures having their different standards, their different cultural norms, we can have very different interpretations of what is dysfunctional, what would be considered a conflict, what is an appropriate stress response, what are situations that we can or can't talk about. All of those change very dramatically depending on where we're looking. In some areas, expressing your feelings might be frowned upon. That might be a big no-no in a particular culture. So maybe you are comfortable interacting with, say, coworkers and being very informal. There are other parts of the world where your work environment is something that is always formal and structured, and you can't show emotion or make those deeper connections. There's lots of different standards depending on where you are, and this is going to affect pretty much everything else when we start looking at therapy and seeking therapy and the effects of therapy. So cultural norms are a definite massive factor. And we can also start seeing that individuals might be a lot more comfortable seeking help within their own culture. So you might be more comfortable seeking someone who understands the norms that you come from, that you're used to. So you might be more comfortable with somebody who understands how you were raised, what your values are. If you are from a collectivistic culture, that might be something that's important for you in a therapist. And one of the problems, especially in Canada, where we are a very multicultural nation, is that it's really hard to find individuals who are trained with a particular background who also match the culture that you are from as well. And so some individuals might be reluctant to seek therapy because they can't find somebody who knows where they're coming from. There can also be limitations on language. So if you're in a primarily English-speaking area, but English is not your primary language, it can be really hard to feel comfortable enough to open up, to discuss feelings and things like that with someone who doesn't speak your native language. So that can be another barrier to seeking out therapy. We also run into issues with access to treatment. So is it covered? Is it part of provincial healthcare or not? Is it something that has to be out of pocket? Is there even somebody in the area? This is especially problematic in rural areas. So once you're outside of the city, is there actually a therapist within your range? Can you get transportation to them? So there's a whole bunch of other factors there that can play a role. Again, with the cultural component, there are some therapies that are more effective for certain cultures over others. So if we were looking at our empty chair role, some cultures, especially collectivistic cultures, would really frown upon things like, say, mimicking or role-playing conflict with your parents. Or with elders within your community, because you're supposed to respect them. So showing anger and lashing out and going through that process in that situation might not be something that's acceptable. So you might not want to try that technique in an area where that's not something that's done. So a whole bunch of considerations that would run in the background. One of the goals, or at least one of the things that might be approached in the future, is the use of culturally competent therapists. And so these therapists would be able to use knowledge about a client's culture to achieve a more broad and inclusive and holistic understanding of the client, because they specifically understand that cultural background. This is one of those factors that usually drives people to want to find someone who has a similar background to them, so that they can feel understood and that they understand the whole picture that they're in. You also want to have that background so that you can have deviations from cultural stereotypes. So one of the problems is if you are trained, but not sort of from a particular culture, you might only know sufficient information from your training, from what's in your textbook, from what you've been told, but that's a forming of a construct of a stereotype, and it isn't necessarily as accurate. So you'd have to acknowledge those limitations and be able to adapt and acknowledge that individuals will differ from that, so it can be more effective. So you have to understand both the individual and cultural differences and consider both. So it's a lot of moving pieces there. So that's the cultural aspect. There's also a gender aspect with psychotherapy, where you might be more comfortable working with somebody who is your own gender. So maybe women are more comfortable with women and men with men, but there's also the consideration that we've kind of mentioned before, where things like anxiety and depression might be more common in women because of things like a lack of control of their life circumstances. We mentioned how feeling like you have control can actually be sort of one of those mitigating or buffering factors that helps reduce the effects of stress. So that can be problematic if people don't have that. So having sort of that historically oppressive environment can cause problems and needs to be considered when conducting therapy with these individuals. So you want to focus on supporting people in their choices in order to meet their needs. So what are their goals? Are they wanting to align more with gender roles or less? Are they trying to overcome things, or what's going on? So there's been a bigger push lately for gender sensitivity, but it's interesting that they're actually finding that while some people initially feel that they may be more comfortable with someone of the same sex, if that individual shows sensitivity and shows understanding and shows sort of that genuine connection, the sex of the therapist is less important than that connection with the individual. So it might not be as important as individuals think when they get started. And that's a very small amount of slides for what is actually a very large chunk of issues, but we're doing a big sort of summary of this section. Our next section is actually going to be looking at, well, which of these different therapy techniques is used or has merit or has benefits, and how do we actually decide that? So how do we evaluate each of these different psychotherapies? Because we've talked about sort of considerations and what they may or may not be good at and how they kind of work, but how do we decide which ones are providing benefit or not? What's our approach? So this is a little bit more methods and considerations of the science as opposed to the methodologies of the particular therapies themselves. But this is equally important because if we've talked about, yeah, this therapy is effective in this situation, how do we know? So one of the first things that we actually have to start considering is the question of specificity, because when we're trying to evaluate psychotherapies, it isn't just the therapy on its own. The therapy has an interaction with things like the therapist. So certain therapists are going to be better or worse at different types of therapies. Are they going to be better or worse for certain clients? For certain clients with certain kinds of problems, for certain clients with certain problems that have certain outcomes in mind. So all of these different factors start interacting with one another and making the situation very complicated. So when we're typically looking at the effectiveness of a particular therapy, we have to keep in mind that it might be really, really effective in some situations and very ineffective in others. And if we want to have a good evaluation, maybe we need some way of measuring that. But if you're thinking sort of statistically, the more of these aspects that we want to start tracking, the more data that we need in order to actually get a statistically significant or relevant number at the end. So the more we start considering, the more data we need, the more stats we need to run, kind of the murkier our answers get. So a lot of this starts causing problems. And for some of our difficulties, a lot of situations where people are going to therapy, the goal is the client feeling improvement? Do they think it's helping? But in a lot of situations, they don't necessarily track any kind of standardized measure. So a lot of the variables that we might be interested in aren't typically controlled. We might have very different measures between therapists, between companies that employ therapists, between situations. There's a whole bunch of those moving pieces. There are a lot of different client-therapist interactions where sometimes they have positive interactions or negatives. Sometimes they work well together. Sometimes they don't work together at all. We have the therapeutic effects, the outcomes. Is it effective? Yes or no isn't really a useful answer. How do we quantify how effective it was? So maybe we can look at a distress score. So perhaps they have your distress score on intake and your distress score upon sort of your graduation from the program. How much has your distress declined? Well, that might work if the therapist uses the same distress score for everyone within their operation. But what if a different therapist uses a different score? Can we compare between the two? Not necessarily. So we run into those moving pieces once again. And in a lot of these situations, who's actually in charge of measuring these outcomes? A lot of them are going to be self-report scores. And we've already discussed how unreliable somebody's self-report measures can be, so that can be definitely very problematic. So sometimes when we're trying to look at these different studies, we're looking at things like a therapist's ratings. So does the therapist think that you have improved over time? Have they quantified that, or is it more of a qualitative description? And we can only really get statistical measures from something we can put into numbers. We can get our client self-reports we mentioned. We might have ratings of the client by their friends and family. So sometimes if we're trying to evaluate the effectiveness of a therapy, if we don't trust the individual undergoing therapy, we might ask others, how much have they been engaging in the problem behavior that brought them to therapy? Is it more or less? Have we seen an improvement? Can we quantify it? Or we might have direct behavioral observations. We might use self-monitoring of that particular behavior. But again, self-reporting of a behavior, we might have changes based on intentional or unintentional loss of information. A whole bunch of different problems there. So that's just all different ways of us saying that collecting data to try and run statistics to see if something is effective or not can be problematic because there aren't a lot of standardized measures. The sources of the data are going to be inconsistent and or unreliable. And not all of this stuff is ever even bothered to be reported because there isn't any kind of standardization to run these multi-comparisons. So it's problematic at best. We also start seeing some other potential problems. So one thing to consider is spontaneous remission, where if we look at individuals who don't receive therapy over time, so they might have really high distress scores at the time of a study starting, but they're in our control group, so we don't send them to a therapist, we just let them continue as they are, they might improve over time just because their situation has changed. So their distress score might drop. We actually typically see what's called a regression towards the mean, where if they started with a really extreme score, over time they're probably going to drift towards a more average distress score just because of the passage of time. So if we didn't actually have a control group and a treatment group to compare the two, if we just saw that, hey, people are getting better over time with treatment, how do we know that it's the treatment versus spontaneous remission? Because in a lot of cases, a lot of these studies are just looking at people in therapy. They typically don't have that control group to compare against in order to consider other variables, other things that might be going on in the background. And so if we start asking broad questions like, does therapy work? It's a really much more complicated question than what it seems on the surface. And we have to start considering, okay, well, Does this therapy work for what it was designed for? Does it work overall? What are we specifically asking in combination with all of those other specificity questions we mentioned before? So it gets really messy, and we need to keep that in mind when we're looking at those reports of this particular thing is very effective under these particular scenarios. If we wanted to have a good way to try and evaluate psychotherapies, if we wanted to have sort of the ideal setup and we wanted to say, is this type of psychotherapy effective? How would we probably set it up? So usually our best design is going to involve something called a randomized clinical trial. So this is usually going to involve the random assignment of clients to either an experimental or a control group. This isn't usually how it works out in the real world, but let's say that we have somebody who's proposed a new type of psychotherapy, something that's never been tested before. They're trying a completely new technique, and we want to know if it needs to be, or if it would be approved. Is it something that should be employed? So we would set up a randomized clinical trial. We'd get 1,000 participants. 500 are going to receive the treatment and 500 are going to receive nothing. And we're going to see if there's a difference between the two groups at the end. Having 1,000 people is probably very optimistic, but that was an easy number to come up with. We can have different kinds of controls. So no treatment would be one type of control. The problem with that is if you have somebody in a no treatment group, they realize that they're not receiving a treatment. So they know that they are not expected to get better. So we would remove or have this sort of extra factor that's going on where the group that receives therapy knows they're receiving therapy and expects to get better. The group receiving nothing doesn't expect to get better. And we've seen that expectations can improve reality. So we can actually find that there would be a benefit just because they expect to be improving. So ideally, what you'd want to do is include, say, a placebo control condition, where in that situation, you'd have sort of a fake treatment. So maybe instead of getting them to talk to a therapist, you get them to go to a meditation class, or you get them to go to an exercise class, or you get them to do something to sort of account for that expectation. It's really hard to employ a placebo with therapy because it's really hard to trick people into thinking they're receiving therapy. But there are sort of slight ways around that. Maybe you can compare them to some other effective treatment. So what if we know that this other treatment has been used for this disorder in the past? So that's what we're going to compare it against. In this situation, our biggest concern is we want to see how this therapy performs against something else. We need something to compare it to. We need a point of reference. So a comparison to nothing, a comparison to a placebo, or a comparison to the existing standard are all going to give us reference points to work from, and it's going to help us evaluate how effective is this particular treatment. And then our American Psychiatric Association, of course, has guidelines for our randomized clinical trials. So they have special rules and regulations for this trial to be considered official so that its outcome, so that its results can actually be considered when they determine if this new therapy should or should not be used in the future. So they have to make sure that the procedures are exactly followed. So you set out standardized rules and regulations, and they have to be followed to the letter. We need to standardize things as much as possible because we need to reduce as many external variables as possible. We have to have some kind of observation. We need a record of what was going on so that we can evaluate it and make sure everything was followed. So maybe we have tapes or recordings or observations of somebody who sat in on the sessions. Some record needs to exist. So these individuals, if we have physical people doing the evaluations, they need to not know which condition the clients are in, because we can have those biases that creep in from our judges. If we know that somebody is in a control condition, maybe we're going to bias towards lower scores because of our own expectations. So you want to keep this in the dark as much as possible. We also want to have some kind of measure of behavioral improvement. So we want to see, where did they start? Do they have a particular distress score? Do they have a particular amount of a maladaptive behavior at the beginning? What about during? What about after? We want to see if there's a change over time. So we need to monitor that. And usually what they're going to want to do is not just sort of before, during, and after the therapy, but also as a follow-up. How long is that therapy effective for? Is it good for 6 months, a year, 2 years, more? So you would have longer-term follow-ups if possible. Another thing that we can use are our meta-analyses. So I think we've mentioned a meta-analysis before. This is basically just a statistical technique where we can combine multiple studies in order to basically give us a better effect size. So typically, one of the limitations we run into is when we conduct a study, we might be limited with the number of individuals we have access to. Smaller sample sizes can lead to uncertainty in our data, which can make our conclusions less concrete. If we can take our results and we can look at somebody else who did a very similar study in a different place, and somebody else who did a much larger similar study somewhere else, and we can combine all of that together and start evaluating the data as, instead of 3 separate sets, but one larger data set, we can actually end up being much more confident in our results. It can give us a much better effect size. So it can give us some indication of maybe what percentage of clients receiving therapy had more favorable outcomes than the average control client. That would be a really hard determination if our sample size was too small, but if we can look at multiple studies, we might be more certain in that determination. We might be more confident in our conclusions. Typically, if you're interested in an area, finding a meta-analysis that's been conducted on, say, all research that's been done in that area is one of those sort of golden moments where you're like, yes, somebody found all of the literature up to a certain point, condensed it all, and considered it objectively. Let's see what the consensus is in this area. These are not as common as other studies, but when you find them and they happen to be in your area, are super, super useful. And on that topic of how many people started showing improvement, this would be meta-analyses outputs to compare a bunch of different types of therapies that we've talked about, where even, so psychodynamic therapies were showing improvement, client-centered showed improvement, Gestalt theories show improvement. We have a whole bunch of these that end up showing fairly high levels of improvement. Our Gestalt therapy is the lowest, but still about 60% patients who who improved versus the control. That's not a bad score. That's still better than average, so maybe we'd consider these all effective. Another thing that we might want to consider is called clinical significance. Basically, when the clients are done, when they have sort of finished, they've gone through their treatment, is there an actual difference here? So at the end of therapy, clients who sought treatment for that particular order have they returned to the point where they'd fall within the range of those not experiencing that particular problem? Have they gone from somebody who classified as having a particular problem, a particular disorder, and have they fallen back into the range of normal or not having that disorder? So that's what we are calling clinical significance, is have we gone from that diagnosis to no diagnosis over the course of that action? Because one of the things we need to consider is we can show an improvement. We can show that we started with a particular score and it got better, but better doesn't necessarily mean that the problem has been solved. So this is the way that they're asking, have we returned to the average? Have we returned to that average range? If so, we can say that we've gotten sort of away from where we started and to a better diagnosis or a lack of diagnosis. This is where we would call it a significant improvement. But typically papers are going to state what they're determining an improvement or what their standards are, but this is one that's very commonly used. This is just meant to show that there are a bunch of different factors that can affect the outcomes of therapy. And a lot of these are just reiterating what we've been talking about, where there are different variables that are related to our therapist. So have they shown those things that we care about, our empathy, genuineness? Do they have experience with this particular disorder, with this particular technique? There's all sorts of things that are involved there. We have variables that affect our client or that come from our client. So the nature of their problem, their motivation. If the client is not motivated to participate, if they're being forced there by their parents, maybe they're not motivated to participate, maybe they're not motivated to make changes. If they don't have that motivation, we'll actually see a very low probability of them improving. And then, of course, the technique itself is also going to play a major role. So are the timings, or are the interpretations coming through at correct timings? Are we using the techniques that apply to this scenario? Is this something that's effective for this particular diagnosis? All sorts of different moving components. Actually, I do have more details. So we talked about what was the term I was using? Client motivation. So that might tie into openness. Are they motivated to actually talk about themselves, to share, to open up to that therapist? Are they going to invest in their therapy? Are they going to take risks by talking about things that they might not want to talk about with others? If not, it might reduce the effectiveness of that particular therapy. We want to look at self-relatedness. Are they able to experience and understand different internal states? So one of the things that some therapists will use is actually a diagram that helps people use the correct words to talk about different feelings and experiences. Because talking about the specific emotions that you're experiencing, not everyone is really good at that. So if you don't have the words to describe a particular emotion or a particular internal state, it can be really hard to get across what you're talking about. And so they might have resources that try and help facilitate this ability to understand and talk about your own internal states to help facilitate that component of therapy. It can be really difficult if people are very disconnected from their own emotions, or if they don't know what they're feeling, or if they're trying to not feel those internal states. It can cause problems. We also want them to be able to make connections and start saying, okay, well, I learned this in therapy. It also applies to this real world scenario. So that's also going to be very important for this component. And then, of course, the problem that the client is having, it actually has to fit in with the therapy that's being used. So if you sought out treatment for diagnosis X, you actually need to be working with someone who has a way to treat that particular diagnosis. For the therapist variables, most of these we've already talked about in other places. So empathy, so that feeling of connectiveness. There are unconditional acceptance, where people don't feel judged, being genuine so that they know that you are sort of truthful in what you're saying, fostering trust and caring, making them feel safe and comfortable. Those are all going to affect how that client opens up. So definitely very important variables. A lot of the stuff when we get into our different techniques, so the different strategies that we're choosing, individual therapists, like I said, they're all going to have their own specialties. They're going to have stuff that they are really good at using, maybe because of experience, because of training, because of whatever the scenario. And as they have more and more experience, the different therapists will be responsible for selecting and implementing whatever the most appropriate technique is for this particular client in this particular scenario. So if they select the wrong technique, it might not be as effective. It might not help that scenario. And we want to make sure that we can actually have the appropriate amount of treatment. And we actually usually want to try and evaluate sort of like that diagram where we were looking at how quickly the amount of benefit starts to fade, where in our earlier sessions, we typically start seeing rapid improvement for fewer amounts of sessions, but eventually we hit that sort of plateau point, where in that first diagram we were looking at, we saw that after about 10 sessions or so, we no longer see the same kind of payoff. So at that point, is it worth persisting in this particular therapy, or is that the point where you start reevaluating, finding something else, maybe moving on to long-term maintenance behaviors rather than sort of our short-term therapy approaches? Again, more moving parts here. So things that are going to be involved in having an effective therapy or an effective relationship and situation. If the client has faith in their therapist, that's typically a positive option. So if the client believes that they're receiving help and they believe in their therapist, that's usually going to correlate with better performance, better outcomes from that particular therapy. It's also really beneficial for them to receive plausible explanations for their problems. People like to understand what's happening. Why am I feeling this way? Why am I experiencing that? So it gives you alternative ways of looking at yourself and the problem by saying, hey, this is what's going on. A little bit of a personal example. I have a tendency to faint in medical conditions, which is really, really annoying because I came from biology. I sort of understand the whole physiological processes, and I'd always feel really weird because I go and I donate blood, or I have attempted to donate blood, and I continually faint on them and have been told to stop coming. But I got really embarrassed about that. I felt that it was sort of a self-failure, but I actually had a nurse who explained it was like, oh, you actually just have a really weird reaction to your fight or flight response. You have an overpowered vasovagal response where when your body ramps up for fight or flight, you calm it down so much that you actually bottom out your blood pressure and faint. She's like, I do the exact same thing. I understand the process. I know what's happening. It's just how my body works. And it was like, oh, that's what's going on. And so as soon as I had that explanation, I actually stopped feeling really bad about it. And so now I have the terminology to explain it. So if I have to go and get blood work done, I just say, hey, P.S., I tend to get overactive and I will likely faint on you. No big deal, it happens. And that puts other people sort of at ease, and it also helps me relax as well. So it very much changed my approach to that scenario. So if you think about it in terms of, say, a psychological disorder, having an explanation, having that understanding, knowing what's happening can absolutely have a similar effect where you stop feeling as worked up about it because you know what's going on. You feel a little bit more in control. It's definitely beneficial. Having a good environment. So when we were talking about our client-centered therapies, we were focusing on that safe environment, being in a good place where you feel safe to disclose information. So that ties in here. Having a protective setting and a supportive relationship with your therapist is definitely going to correlate with better outcomes in therapy. You're comfortable talking, you're comfortable sharing, and you're going to feel safe in employing some of those things you talk about. We also want to have opportunities to practice those new behaviors. So if you learn something that should be helping, say, mitigate anxiety, by being able to practice that in the real world, you're going to get more benefits from it. And if the situation can end up increasing your optimism and self-efficacy, so optimism would be kind of like our reframing of the way we think about things. So more positive thought framings are going to be beneficial. Self-efficacy, feeling like you can do something, is definitely going to make you more likely to do it. These are all going to lead to better performance after the fact. Whew. All right, so getting a little bit further on, we get into our biological approaches to treatment. So we haven't really touched on medications or different biological ways that we can start treating different disorders, and that's what this section is going to start getting into. So we're going to look at drugs, we're going to look at electroconvulsive therapy, and we're going to look at psychosurgery. And if we still have some time, I might go off on some tangents, but I'm going to try and hold off. But For the concept of psychopharmacology, this is the study of how drugs affect cognition, emotion, and behavior. So we know we're not super well versed on how our brains and our neurotransmitters and all of those different chemicals work, but we're working on it. It's an ongoing process. With this psychopharmacology, there are tons and tons and tons of prescriptions written every year. And because anxiety and depression are some of our most common disorders, we see lots and lots of anti-anxiety medications, antidepressants. We also see antipsychotics, so like those that would be used for those with schizophrenia. So these are fairly common drugs that are prescribed, and our understanding of how they work is, again, kind of shaky at best. When we look at our antidepressants, we have three main categories that are typically prescribed. The first being our tricyclics, and these increase activity of norepinephrine and serotonin. I believe they also affect dopamine as well, but dopamine ends up with its own complex process, so they mainly, the goal is to affect these two, and it tends to also influence some other stuff downstream that we don't focus on. But the way that they work is they're increasing the activity of these two neurotransmitters by preventing the reuptake of them. So basically, we're saying that reuptake is that process of cleaning up after neurotransmitters have been released into the synapses between our neurons. So if we reduce the cleanup process, those neurotransmitters that were released will hang around for longer. So instead of having to make and release more of them, the ones that are there are just active for longer. And if they're excitatory neurotransmitters, that just means that they're more likely to create action potentials. We're more likely to see activity in the neurons that are affected. So if we don't clean them up, we see more firing because these excitatory neurotransmitters are active for longer. So these would be targeting different disorders where low levels of things like norepinephrine and serotonin are causing problems. And specifically, so it's antidepressants. So depression, especially we're going to see, is related to a lot of serotonin. So low levels of serotonin, we artificially boost it by not cleaning it up. Our monoamine oxidase inhibitors, or MAO inhibitors, they increase the activity of norepinephrine and serotonin once again, but here the mechanism that they do it by isn't by preventing that reuptake. Here, they're actually going to be focusing on reducing the presence of that monoamine oxidase. So it's an MAO inhibitor because it's affecting that MAO. So an oxidase is a thing, it's an enzyme that breaks down specifically norepinephrine and serotonin. So if we are stopping the functioning of the thing that breaks those neurotransmitters down, they're going to hang around for more often. So they're going to be present again in that synapse and active for longer times because they don't get broken down. So reuptake and breakdown are our two methods of cleaning up what is in the synapse. So they're both doing the same thing, just with slightly different approaches. So one is blocking the cleanup process and one is blocking the breakdown process. Then we get our selective serotonin reuptake inhibitors, or SSRIs. And these are targeting serotonin only, not the norepinephrine as well, and they're specifically blocking reuptake of serotonin. So because of that selective component, because they're not affecting as many receptors as the others, this has a slightly milder effect, so it tends to have less intense side effects than other antidepressants, which is why this is usually the preferred category that people will get diagnosed first, but it's still fairly effective. And because of its sort of selective targeting, it helps reduce those depressive symptoms a lot more rapidly. One of the potential side effects that can come with this, though, is if we're reducing symptoms of depression, it can come with increased symptoms of anxiety. We'll actually kind of see that there's a little bit of back and forth between the two, and we especially see that depression and anxiety tend to be comorbid fairly often, meaning that individuals with one are more likely to also have the other. But yeah, I forgot that I included these visuals because we were talking about the process. So reuptake is that process of cleaning up our synapse, recollecting those neurotransmitters, the triangles that had been released, and then bringing them back to the presynaptic neuron. Just our remembering. So the synapse is the gap in between our two neurons. So that's where we're communicating. So our action potentials move down one neuron. So our presynaptic neuron, we travel down that. We get to the end of it, our axon terminal. We then release our neurotransmitters to transmit that signal across the synapse, across the gap, to our postsynaptic neuron. We're going to bind to the dendrites there, create our new signal, and sends off an action potential to the next area. So it's just sort of a process where we go from electrical signal to chemical signal to electrical signal. The process of sort of resetting to allow the next signal to occur is going to involve this reuptake process. So an SSRI is blocking that reuptake. It doesn't allow us to collect and restore those, so it stays there and stays active on the other side for longer, has more of an effect. And then this is another of those diagrams that I borrowed from a different source. So it shows our SSRIs, our MAO inhibitors, and the tricyclic depressants, just showing that what they're affecting and where they're affecting it, but the same visual, what we just talked about in words, but now in a picture. All right, next we get into our antipsychotic drugs. So these are going to be helping to reduce psychotic symptoms, basically stuff that's going to be affecting things like hallucinations and other, say, positive symptoms like of schizophrenia. I keep referring to schizophrenia because it is one of the most intense psychotic disorders, and it tends to affect a very large number of individuals. So this is something that affects almost 1% of the population at any given time. So it's actually a pretty large effect, and especially those positive symptoms tend to be really intense. And the positive symptoms actually respond fairly well to antipsychotic drugs. But like I said, those drugs have some weird side effects. So we accidentally learned that things like schizophrenia, so the production of delusions and hallucinations and other psychotic oh man, I'm blanking on the word there, psychotic symptoms. Symptoms is the word, not a great one to forget for this lecture. But a lot of it seems to correlate with sort of too high levels of dopamine. So typically we assume that it's because we have too much dopamine in our brains, and dopamine is one of those excitatory neurotransmitters. We typically talk about dopamine as it relates to things like our reward pathways in our brain. So it would activate the pathways that help us feel good. And one of the potential explanations for hallucinations and things like that is that by having more of an excitatory neurotransmitter active is that we're getting stronger signals than what we should be getting from our environment, and we start interpreting those artificially boosted signals as reality. So we get these activations that don't actually technically have proper sources, and we interpret them as things in the environment. So you might take your inner monologue, and because it has substance and it feels like it's real and external, you assume that it's external voices. One of the theories that goes along with hallucinations. But our antipsychotic drugs typically target this high level of dopamine and will try and reduce its action. So most of them are going to be targeting those positive symptoms, and they're going to reduce the activity of dopamine. Mostly what it does is it actually targets the receptors, so the pieces on our postsynaptic neurons that actually bind to and react to the dopamine. So we typically don't affect how much dopamine is produced, we just affect how our brain responds to it. So we make our brains less sensitive, so they stop reacting as intensely, helps reduce those symptoms, things like delusions and hallucinations. This mode of action tends not to have much effect on the negative symptoms. With schizophrenia, negative symptoms are usually a lack of something. So if people have very few emotions, they show apathy, they are unable to move, they are unable to talk, those would all be negative symptoms. It's a lack of normal functioning. Our positive symptoms are usually an excess of particular actions. So they hear things that aren't there. They're thinking things in a maladaptive way. They're showing emotions that they shouldn't. So if it's too much of something, it's positive and it responds really well to this balancing out of our dopamine levels. But if it's negative, it tends not to be affected by these dopamine adjustments. But one of the biggest problems that they found, especially with the early versions of these antipsychotics, is that because they're messing with how our brains process dopamine, it also tends to affect other dopamine-related symptoms. Specifically, our motor systems tend to rely very heavily on dopamine. And so we see something called tardive dyskinesia, which is a very severe movement disorder. So individuals will start showing tremors as they have this reduction in dopamine for long periods of time. Typically what happens is if you're on these antipsychotics for too long, we start to see that some of the cells that usually respond to dopamine will start dying off because they're not being stimulated the way that they're supposed to. And as we start losing those cells, we lose brain volume in those areas, and we tend to start seeing problems with our muscular function. So we'll start seeing tremors. And once this has happened, once we start seeing symptoms, we've usually had sufficient cell death that those symptoms are not reversible. And when these were originally proposed, these antipsychotics were really the only option at the time, and they were prescribed in very, very high doses. And at the first point, when they were really first proposed, they'd actually prescribe them in high enough doses where the indicator that you were at the right level was that people started showing tremors. So they used to crank it up to sort of maximum dose as quickly as they could, but the problem was it caused long-term irreversible damage very, very quickly at those levels. Even once they figured that out and they started reducing the dosages, being on these drugs long-term still caused those same problems, to the point where just being on these first-generation antipsychotics, at some point in your life, you would probably end up with this movement disorder. So definitely not ideal. And one of the biggest problems was that despite these sort of bad side effects, it was actually very, very effective. And so when these were first released, so these came out in sort of the 1950s, and this was one of the first times that we started having very effective treatments for a lot of these positive symptoms. And these positive symptoms were one of the large contributors to people who were being locked up in what they called insane asylums at the time. So up until that point, they had this massive increase in the number of inpatients hospitalized because they had a lot of these positive symptoms, couldn't function on their own, and there was no existing treatment. So they just kept gathering more and more people in these hospitals, and they couldn't release them. But once these drugs were developed, once they were sort of shown to be effective, they had this massive decline where they were able to start helping people with these symptoms for the first time ever, and they were able to drop off the amount of people that had to be hospitalized all the time. I don't think I have a slide for it here, but there is actually a newer version of these antipsychotics. So our second generation antipsychotics are actually one of those really fortunate situations where they found something that worked by targeting dopamine once again, but not with the same intensity. So we actually end up seeing a reduction in our motor problems, but we, instead of seeing a reduction in the effectiveness of treating our symptoms, we actually saw a corresponding improvement. So by targeting more specific receptors instead of a blanket targeting of dopamine, we were able to see a 15 to 20% improvement in symptom treatment without the same risk of the tardive dyskinesia. So our second generation antipsychotics are actually just all around better. So instead of having to have a trade-off between a really nasty side effect and less effective treatment, we got no side effect and better treatment, which is very rare to experience, especially with drugs like this. Our next type of therapy is electroconvulsive therapy, or ECT. And this is one of those really, really controversial types of therapies. And this is one that's really, it was used very, very commonly commonly around that same period, sort of the 1950s. This was all the rage. It was used for a bunch of different things. Basically, they started realizing that people with schizophrenia very rarely also had epilepsy. And epilepsy was developing seizures because of strange electrical patterns and firing in the brain. So they figured maybe the electrical signals from epilepsy are preventing the symptoms of schizophrenia. So let's apply electricity to people's brains and see if it helps with the symptoms of schizophrenia. And strangely enough, it actually ended up working for some disorders. This is really, really effective in treating severe depression, especially in individuals that are treatment resistant, or specifically drug resistant depression. So this can be very effective. So about 60 to 70% of individuals will improve after ECT, which is a pretty big approval rate. And the effects can be immediate. So one of the only reasons why they still will use ECT is for very severe cases of depression that's been resistant to other forms of treatment, especially if the person is in very, very bad shape right now. So if someone is very suicidal and showing no improvement, this might be sort of a last-ditch effort to try and fix that quickly. The procedure nowadays is a lot less intensive and violent than it used to be, and a lot of the media representation still lean into the sort of intensity that we used to expect from the 50s, but nowadays, if they're doing this procedure, they usually sedate the individual and give them a muscle relaxant, so they're not necessarily awake for the procedure. Their bodies aren't going to go through full spasms like you'd see on TV. The shocks themselves last for less than a second, so it's not like a long-term stimulation. And it just causes a brief seizure in the central nervous system. So we're shocking parts of the brain to try and sort of reset different areas. Of course, there are going to be criticisms. So the possibility of relapse is fairly high. So this is typically a short-term treatment. It can deal with symptoms right now, but you'd need something to affect long-term or to repeat. There is the possibility of pretty negative side effects, things like memory loss or brain damage if it's done incorrectly. Those are, of course, reasons why this is starting to fall out of favor. So currently, if it's used in those sort of specific scenarios, the number of treatments that an individual can receive across a time span is very limited. And they have to do follow-up scans to make sure that nothing is going wrong, that there isn't any long-term damage in order for them to carry on with it. Something fairly similar that's actually a lot more common, again, new enough that it hasn't made it really into our textbook, would be something like transcranial magnetic stimulation, or TMS, which I think we mentioned briefly back in chapter 2 maybe, or it might be a 104 thing, I can't remember. But transcranial magnetic stimulation is basically the application of magnets, magnetic field across the skull, transcranially, in order to disrupt firing within different parts of the brain, or to encourage firing in different parts of the brain. So kind of like this, but with more control. And a lot of really cool studies lately are showing that TMS can be effective for a lot of things like anxiety and depression, but also things like addiction and seizures as well, depending on where it's employed and how it's employed. So you can change it to increase or decrease activation in very particular parts of the brain. So if you wanted to increase happy thoughts in order to sort of reduce the functioning of depression, you can target those emotional areas and try and improve those pathways. Next, we get into psychosurgery, another thing that's, again, in a very sharp decline. A lot of these techniques, very, very common in the 1950s and have reduced over time as we start learning more about how stuff works. But psychosurgery is looking at removing or destroying different parts of the brain to try and alleviate symptoms. So this, again, common before we knew what different parts of the brain used to do. So if you remember our case study of HM, who is very important in terms of memory because he had severe epilepsy, he had really bad seizures, and so he had parts of his sort of central cortex area removed, specifically the area around his hippocampus. He is one of the main reasons why we know that our hippocampus is involved in memory, because after that structure was removed, his seizures stopped, his health improved, but he wasn't able to form or retrieve memories the same way. So it solved the problem they were trying to solve, but it also taught us what those areas are also employed for. So case studies like that are one of the reasons why we try not to remove large portions of the brain unless absolutely necessary. So there can be extreme scenarios where it's still used. So if you have, say, life-threatening seizures, maybe they would damage the part of the brain where the seizures originate from, but it usually comes with some pretty intensive side effects. Again, before they knew about all these side effects, they used to do things like lobotomies, where they would destroy a bunch of the nerve tracts heading into our frontal lobes. Specifically, this would try and sort of reduce some of our impulsive behavior, specifically because it was affecting the part of our brain that was controlling impulsiveness and personality, and it made people a lot more docile and likely to follow instructions. So it was very common when a lot of people were being hospitalized and they wanted to stop them from being aggressive, but it was causing permanent damage. So the usefulness of this started decreasing as our antipsychotic drugs were introduced, and we could get very similar outcomes without causing physical damage, so they preferred that technique. We'd also have cingulotomies, where you might cut the fibers that connects our frontal lobe to the limbic system. This is a lot more of a precise interruption and can be useful in cases of severe depression and OCD. But again, it has to be very, very severe in order to convince somebody to do this task because of the potential for disrupting other functionality and causing long-term problems. And so this section is actually just getting into how do we evaluate the effectiveness of different kinds of treatments. And we've actually found some evidence through PET scans that different psychological and biological treatments can have an effect on brain functioning. So we can actually see changes in the activity patterns within our brains because of both biological treatments, so stuff that's changing neurotransmitters, but also with some of our psychological treatments. So we can see changes with psychotherapies. So even if we're not having sort of a physical change of our neurotransmitters from introduction of drugs, we're still seeing changes in activity from changing our thought patterns, which is really, really cool and really important to be documenting. So psychotherapy and drug therapy showed very similar changes in blood flow. And if blood flow is our indicator of activity in those areas, that is something that's really important. If we're seeing very similar patterns, very similar changes, and those are changes we want, it might say that if people don't want to be taking drugs, if they're okay with psychotherapy, they can get similar results. So it doesn't have to be prescription drugs all the time. There are alternatives that can get us to the same place. And so this is just the reports showing that, comparing our SSRI, which is one of our antidepressants, and a psychotherapy, and we're seeing reduction in neural activity. So those changes in our activation in our amygdala, our hippocampus, and our temporal cortex. So our amygdala would be that area responding to fear and anger and sadness, our emotional stuff. Our hippocampus would be involved in sending memories off for consolidation and retrieving them. And our temporal cortex would be sort of towards the front here. And that's going to be involved in sort of some of the processing stuff that we have. So one of our association areas is there. But yeah, so we're seeing comparable relationships between the two, which is pretty cool. Oh, I apparently did include a slide on TMS. But I talked way more about that than what's on the slide, so we can skip that. I always forget when I include new slides, because that was a new addition. Okay, so the last couple of slides just come from a section in our textbook that was looking at psychological disorders and society. Basically, what else can we be doing, or what else might we consider? So the first of these is the concept of deinstitutionalization. So from our diagram before, where we were seeing the number of hospitalizations and how it peaked in the 1950s, there was a really strong push to have people treated as inpatients, where they wanted to remove them from society, send them off to our asylums, and sort of keep them separate from everyone else. And at the time, that was effective because they didn't have any way of treating them, so keeping them in a theoretically safe environment kind of logically made sense. But if you look into the history of asylums and the whole process at the time, it is a very dark history. But if we start looking at this movement away from inpatient treatments to allowing people to maintain normal lifestyles and normal life functioning, we actually start seeing that people tend to have better prognoses if they can maintain their lives. And so we started seeing this shift where in those 1950s, like 77, almost 80% of people were treated as inpatients. In the 1990s, it was only 30% of people. And that number has continued to sort of decline. So moving away from institutionalizing people and trying to treat them as outpatient, basically where they can go and get their treatment and then return to their lives, is beneficial. It's a really good idea. But one of the problems is that the resources need to be available in the areas to allow that to happen. So if somebody requires particular treatments, particular things available to them in order to stay at home, those need to be available, or else they will have problems where they will escalate. So if they can't get their treatment, they might start having relapses. So if an individual with schizophrenia can't receive their medication or can't get treatment when they need to, they might show more of those positive symptoms. It might become problematic, and that leads to what they call the revolving door phenomenon. Basically where individuals end up with getting so bad because they can't function in outpatient because of lack of availability or lack of sticking to the schedule. So they get hospitalized until they get their symptoms under control. They return to the real world and their symptoms rack up again. So it's this cycle of sort of hospitalization until it's under control, back in your life until it's out of control, and then you're back in the hospital. And because of this shift between the two environments, it makes it very hard to maintain, say, a job and a home. And this leads to a large number of individuals who end up having to live on the streets because they can't maintain their job and lifestyle and all of those things. This is actually one of the factors that we see where if you look at studies of socioeconomic status and the occurrence of schizophrenia, we actually see that a diagnosis of schizophrenia is more common in lower socioeconomic statuses. But it's not that being poor causes schizophrenia. It's actually a combination of that, but also that having schizophrenia interrupts your ability to support yourself and causes you to drop down in socioeconomic status. A more recent study of that, because there was a lot of discussion of, is there a direction of it, or is it more common in lower socioeconomic statuses, or does it cause you to drop down? When they run the same studies and use not the individual's current socioeconomic status or income, but their parents, with the assumption that you typically stay in the same range as your own parents, that effect goes away, where schizophrenia occurs equally in all socioeconomic classes. So it causes that downward movement. So it can cause a lot of problems in that case. If institutionalization is something they're trying to push away or lean away from, what other things might be useful? There's been a recent focus on preventative mental health treatment. So if we can try and prevent the scenarios where it gets so bad that people need to seek out treatment, that might be beneficial. I don't know if you've been on campus long enough to notice, but say in the last 10 years, there's been a massive push to have things like peer support groups. So instead of having reactions to people who are so distressed they can't function, let's give them environments where they can meet with others and help reduce stress levels before it becomes too intense. So can we start reducing or eliminating some of our environmental causes of these disorders? Can we try and reduce some aspects so that we don't get to the point where we need intensive treatments? This is a lot harder to justify because a lot of situations where they're choosing, say, budgets, they want to look at, well, what's the cheapest right now? And not doing anything seems really cheap. But implementing a lot of these preventative programs actually has long-term benefits because it reduces reliance on those emergency resources in the future. So this is something that from the numbers actually works really well. And for this couple of case studies where they've tried implementing this, it's been really, really effective. It's just very hard to convince others of that. So it's very slow in rollout. Another thing is a competency-focused prevention. So still on the prevention side of things, but instead of focusing on the situation, now we would focus on giving people the skills and the resources to be able to cope in those situations. So if we teach people how to respond to stress or how to avoid particular situations, that might fall under this category. But basically, we're giving people the resources to stop it from escalating to the point where we require intensive mental health care treatments. But yeah, this is a really interesting topic, and there's a lot more that we could say on it. If you're curious, the textbook has like 5 or 6 full pages on it, but just for the sake of finishing at a decent time, I kept it to these main ones. But we'll leave it there. So that is the end of the chapter and the end of the semester.